for chiming in this evening. We have a lot to talk about over the next, I'd say, 50 minutes, so we have some minutes for questions. So if we can go to the next, we'll just review tonight's objectives that I want to hit as a basic overview of LVADs that we're seeing in the community, and we're going to see more and more of nationwide or international-wide. So it's really important that we kind of remold what we've been doing all these years for our EMS practice, that we now incorporate this specialized patient population. So if we can go to the next screen, Dawn. So we're going to talk about the introduction to heart failure, a very basic overview, the acute and chronic causes of heart failure, a very little bit about VADs, because there's so many different devices now out there that we're seeing. We could spend 2 hours just talking about the different devices, how the VADs are changing our patient assessment, because they do change our assessment significantly. LVADs and CPR, which continues to be an ongoing controversy. Our medical and trauma assessments are slightly different. We have to incorporate these devices into those assessments. And then determining the proper modes of transport and where we take our patients. Sometimes the local emergency room that's our closest facility may not be the best option. And then what special considerations in transport we need to think about. So if you look at this textbook picture, it is basically right out of our textbook. If you look at a normal size versus an enlarged heart, basically we're looking at a textbook photo of heart failure. We have the picture on the left, which is a normal heart, strong left ventricle. We know that's the purpose for our cardiac output. It needs to be thicker in its walls. It needs to be stronger with contractility than the right side of the heart muscle. Then we go to the right and we look at cardiomyopathy. And those are the patients that we're seeing a much broader population in this country and worldwide, more so than ever. And these are the patients who are ending up with cardiomyopathy, enlarged hearts, and they're becoming weaker and less boggy, more boggy and less contractility. So these are the patients that are basically showing your congestive heart failure profile. So we go to the next slide. And this is basically the typical patient population that we see almost on a commonly day-by-day basis. We get dispatched for your difficulty breathing, your shortness of breath. We get there, the patients are in pulmonary edema. They have peripheral edema. They're pale, they're diaphoretic. They're often with low O2 saturations, even with home O2. And these patients tend to have your low ejection fractions, which is obviously the amount of blood flow that's ejected out of the left ventricle for your overall body perfusion. These patients end up being very low with their ejection fractions, which drives them to going down the pathway of needing an LVAD, and they're chronically fatigued and easily distressed. Now, this is the patient population that are more of your chronic profile, not so much your acute, got a virus in my myocardium, and I'm 26 years old, and it runs ravishing, and next thing you know, the next day they're in an OR getting an LVAD because it was more of an acute process than a chronic process. But we're seeing more and more of the patient population appearing this way almost on a daily basis. So now we've come up with a solution to this patient population, and by way of LVADs, we're seeing these patients now becoming better and healthier and less complications such as this. Let's go on to the next slide. So we know some of the acute causes or the chronic causes of congestive heart failure or just heart failure, uncontrolled high blood pressure. I think we're probably all in agreement that when we take our patients' histories, 9 out of 10 have a history of hypertension, which is usually half the time not well controlled for an array of reasons. Multiple heart attacks, which obviously can damage the heart muscle. So we have your coronary artery disease history profile patients. Then we have your more acute processes where you have a virus that gets into the lining of the heart muscle itself. Those are the patients we're seeing that went to bed fine, and then 4 hours later they're waking up and they can't breathe. Severe coronary disease. We see severe coronary disease and diabetes. They're pretty much almost like married. If they don't have one, they're going to have the other not long after. There we go. So obviously diabetes can make coronary disease even more pronounced than just the disease itself. And then, of course, we have your bad social habits, which can also contribute to heart failure. Even though they have uncontrolled high blood pressure and heart disease, They may still hold on to high sodium diets, sedentary lifestyles, smoking, drinking, et cetera, et cetera. So there's a whole cascade of things that can create heart failure and then make it exacerbated to the point where they are now actually a patient profile for an LVAD, which is why this is making this population for our country just even more prevalent. So we can go to the next slide. Patients that meet the criteria for a ventricular assist device, they can no longer be effectively managed by medications alone. They're either, again, acute or chronic heart failure. And it's actually a classification by the New York Heart Association, Class 3, Class 4 candidates, that actually provides you a slot on a scale of how soon you need a transplant. And, a cardiac assist device obviously buys you that time that you may need in order for that transplant to come to fruition. And patients that fall under ejection fractions of less than 25% start to go down that pathway of being evaluated for a cardiac assist device. We know our normal ejection fraction is around 65-70% in a healthy, normal adult individual. So imagine 25% being less than what is considered normal, why these patients present as sick as they actually do. They essentially don't have any perfusion to really do more than just sustain life, let alone an active life. And we can go to the next slide. There you go. There's typically 3 patient categories. 2 of the 3 we will primarily see in the field. We have probably the most popular, bridge to heart transplant. That's your patient that is evaluated for a heart transplant, gets placed on the transplant list, but gets an LVAD to sustain their life until that transplant becomes possible. That may be a matter of months. It may be a matter of years. And depending on how well they do with that LVAD, depends on how well they're placed, where they're placed on that list for transplant. So some of these patients may have these devices for, a couple of years before they get that phone call. Bridge to recovery, we're not really going to see that patient classification because it's pretty much more your internal, still in the hospital. They may only need the device for a couple of days or a couple of weeks, and they're not sent home on the device. Then we have your end destination. And end destination means you have too many other comorbidity problems where you're given the device, you're not a candidate for transplants, so we send you home with the device, and depending on how well you follow the rules and how well you adjust your life around it, depends on how long you have to live with the device. But that's really the only thing that's going to sustain your life is this device. Transplant's just purely not an option. That's an important thing to kind of know when you're assessing these patients, and they'll understand that terminology. If you're a bridge to transplant or you end destination, don't be afraid to ask those questions because it will kind of give you some segue into the history of these patients. If they say, well, I'm end destination, I'm not a candidate for a transplant, that should key you into the fact that they have other secondary problems that are also possibly a complication for you as well in the management of your patient, depending on how long you have them. So that is an important thing to ask and to know when you're assessing these patients. We can go to the next slide. So we're going to talk a lot about these devices over the next 45, 50 minutes. There's a variance of devices now out there in the market today that we can encounter across the country. It depends on what LVAD center is in your area and what device they like to put in. So there's 3 different specific devices. The one that's most commonly that we know and we are familiar with is the left ventricular assist device. It only provides support to the left ventricle. But we also have your biventricular assist device, where both ventricles, the left and the right, are provided support because that's what's necessary. And then we have what's making its way out into society is the total artificial heart, where it's a removal of the native heart and it's replaced with artificial valves and ventricles. And each one of these devices operate differently depending on whether they're pneumatic or they're continuous flow or axial flow devices. So trying to have you remember all of the information tonight is going to be nearly impossible. But the take-home point is just realize there's multiple devices out there and they operate differently. You just need to have some basic working knowledge of the device that you're dealing with at that particular time. So we can go to the next slide. Some LVAD points of attachment. This will segue its way into the CPR situation that we're going to soon talk about. If you look at where the points of attachment are for an LVAD, we're at the apex of the left ventricle, and then we come up to the ascending aorta. If you look at the picture on the left, which is the HeartMate XVE, that was one of the pioneer devices that first came out, at least up here in the Mid-Atlantic region back in the late 90s. It's a pulsatile device, which creates a pulse by the way the device works because it's a pneumatically driven system. The patients would actually have a pulse with the HeartMate XVE. But if you were to look at it, it's very big, it's very cumbersome, and the patient population was very minimal because of its size. Now, fast forward 7-8 years and go to the HeartMate 2, which is on the right side of the screen. That's a continuous flow device. It's no longer pneumatically driven. It just continuously flows at RPMs per minute. So it never stops as long as the device has power. Continuous flow devices tend not to generate pulses. So there's vast differences in how we approached these devices from early in the 90s to late 2000s. But the points of attachment are still the same. The left apex of the left ventricle and the ascending aorta. If you just look at it, though, the sizes are smaller on the right, and where it's located inside the body is actually more conducive to a broader patient population as far as body size. So we've made some pretty big leaps from the left to the right if you look at these two pictures. But that points of attachment are obviously still the same, which brings that controversy referencing chest compressions, because obviously we don't want to dislodge this device. So that's still something that we have to linger on to in today's society, but we'll talk a little bit more about that in a little bit. We go to the next one. HVAD by Heartware is another device that we're seeing out in the community. It operates a little bit differently. It, too, is a continuous flow device that is actually ran by a levitational field that suspends the impeller and the rotor blade to where basically the parts don't touch one another, and it's a continuing spinning motion, thrusting blood flow forward into the ascending aorta. But if you look at the lower picture, you will see where it doesn't actually hang below the left apex of the heart muscle like the HeartMate 2 does. It's actually embedded into the left ventricle and sits right on top of the left apex. So the technology there is slightly different than what the HeartMate 2 is, but the theory is still the same. It augments that left ventricle, provides cardiac blood flow that the heart couldn't do on its own, but the points of attachment are also still the same. It still goes to the ascending aorta, and it still attaches to the left ventricle. Just the mechanics of it just works a little bit differently. If we can go to the next slide. Now, I thought this was an interesting picture to put into this presentation for the surgical placement of the HVAD. It's actually not as traumatic maybe as some of the other devices, but it actually has a little pump pocket that the device sits in, and the implant time tends to be a little bit shorter, and the invasiveness and complexity is greatly reduced. So the recovery time obviously is faster for these patients. The faster recovery times, faster shortened educational curve, these patients end up coming home much, much sooner. And that's really the goal of where these devices are going, to be less invasive to the body and have a shorter educational curve on how these patients process these devices and the emergencies that come along with them in order to get them back home and out into the community sooner and faster. We can go to the next slide. We have the Jarvik 2000 Flowmaker, which is another pulsatile device. As you can see, the device looks slightly different. The picture in the middle shows a little different presentation than the HeartMate 2, but the attachment points, again, are still the same. So we have multiple devices that are out there, some more prevalent than others, But just keep in mind the concepts of what these devices are trying to do, which is to augment that left ventricle when they are specifically an LVAD. If we can go to the next slide. Here's where things get a little bit more complicated and a lot more graphically visual. This is a picture of a Thoratec BiVAD where a patient has dual ventricular support. So they have both a left ventricle support and a right ventricle support. In the picture on the left, here, lost my screen. There we go. The picture on the left, obviously, if you were to do a patient assessment on a patient like this would be pretty much graphically overwhelming to see, because this is not something we would normally see from a patient. But obviously, their pumps are outside the body. That blood flow, obviously, on the left is venous and on the right is arterial, and that is something key for us to be able to assess whether the device is working properly or not, is you'd be able to actually shine a flashlight or a pen light into those pumps and actually see the blood flow coursing through the pumps. But this is another type of device that we're capable of seeing in the field where they may be not very well managed if we take them to the local emergency room versus going to a VAD center that actually placed this device in this particular patient. So visually they can be overwhelming when you see something like this and you're not accustomed to understanding LVADs and BiVADs, especially ones that are outside the body. We can go to the next one. Then we have what's considered the total artificial heart device by Syncardia. This is a whole nother concept. Instead of augmenting the left ventricle, it actually just takes out the native ventricles and the native valves and replaces them with man-made mechanical chambers and valves. This, too, is a pneumatic-driven system, which is different than your continuous flow devices. Usually anything that's pneumatically driven, it's audibly louder than what devices that is a continuous flow. So you can actually hear this device working outside the human body without using a stethoscope. And they're actually pretty audibly loud, which is to our benefit, because as we're approaching the patient, we can tell this device is working because we're hearing a constant tick noise that basically is every time you hear that tick noise, is this device working? So there is some benefit to having pneumatically driven devices. But this is in clinical trial currently, but we do have some patients in the community that are now coming out with the total artificial heart. And if we go to the next screen, you'll see the process in which the patient goes through. You see where the native heart in the first step is removed. The atriums are still left intact. They replace the artificial valves, and they start to put in the artificial attachments for the chambers. And then in the last picture, you see the complete photograph. They actually have bladders inside those ventricular chambers that fill with blood, and as they're completely filled, sensors will tell them to contract. Blood flow is sent forward into the aorta, and then it has a refill time, just like our normal ventricles work. So this device basically is designed to work around how our own heart works, which the HeartMate XVE, when it first came out, it pretty much mimicked exactly that same process, but just the technology wasn't there at that time. Whereas the technology is here today, this device is probably going to prove to be a little bit more efficient as far as how it actually works, and it works longer with less complications. But this is one of the devices now making its way out to the community, so it's not an augmenting device for a failing left ventricle. It's completely replacing the heart itself and all the other components along with it until these patients get a transplant donor heart. This is what they end up living with until either they die or they get that phone call saying they have a transplant waiting for them to be surgically implanted. So just briefly going through all these different devices, as you can see, diversity is the key word here. Just don't get locked in on any one particular device because you have no idea what we may be walking into. especially since these patients are mobile. They can travel. They may not live in your area, but they may be visiting your area, especially if you're a high tourist part of the country. Especially here in the Washington, D.C. hub, we have a high population of specific devices, but it does not mean that we cannot see devices that we don't implant here in this area visiting Washington for a week or two. So just be cognizant that these devices are very, very different and very global. And if we can go to the next slide. Each one comes with a system controller of some kind. In the top left corner, you have the Freedom driver, which goes with the total artificial heart. The picture to the right has what's called the Heartware system controller. The bottom left is the Jarvik 2000 battery and system controller. And then to the far right, bottom right corner, we have the HeartMate 2 system controller. The system controllers are essentially the brains of the operation. They help provide, they're actually a venue of how power is provided to the device inside the body, and they provide you information on how the device is working and if there's any kind of complications. One device, such as the Heartware in the upper right corner, actually tells you how many RPMs and liter flows per minute this device is working with for the Heartware device. The picture in the bottom right is the HeartMate 2. That's more of an alarm indicator and is actually pictures that will illuminate whether it's a heart or a wrench or a green bar telling you what the battery level is. In order to interpret those diagrams, we provide field guides and information to kind of mirror up exactly what those indicator lights mean as far as what the problem may be and troubleshooting techniques. But all these controllers, they look different. They provide relatively the same information, some more, some a little less. But just be cognizant of the fact that they're very, very important, and the information that we convey to the VAD coordinator when we get them on the phone in a 911 emergency means a great deal of information to them. It may not mean much information to us in the field, but just recognizing that these are some type of system controller that provides information and data is the take-home point. To try and remember exactly how each and every one works and what information that they're conveying may be complicated if you don't deal with these devices every day. But just do realize that this controller is a venue for power to the device inside the body, so we don't want it disconnected, and it's connected to some type of power source. And if there's a problem with that power source, go to this controller to tell you that that's part of the problem that you may be encountering. And again, they all look very different, so just be cognizant of the fact that they all have their own individual identities, but there is a key element of value to each one of these controllers in providing you information that you need to either provide to the physician or the VAD coordinator when you're dealing with your emergency in the field. If we can go to the next slide. Here we have various power and module systems. Every one of these devices, regardless of it's an LVAD, a BiVAD, a total artificial heart, every one of them has some type of external power source that needs to be provided 100% of the time for the device to work. So they're either going to be on portable batteries, which is indicative up in the top, or actually the left side of the slide. The top picture, you have your Heartware. Those are portable batteries connected to the controller, and the controller is connected to what's called a power module system. It basically tells them what information that's important as far as how the device is working. You're probably more inclined to see this module in somebody's home. So if you go to the living room or to their bedroom, someplace where they spend a lot of time, they may be hooked up to this, and it's going to provide information for the person on the phone that you're talking with and helping you troubleshoot. But if you don't have that power module system to tell you information, fine, you'll still get it on the controller. But just be cognizant there's two types of power source. Your portable power source, so they can go to the grocery store, they can go to work, they can go to school or wherever it is that they do through the course of their day. that they're going to be on portable batteries. So it's important to know where their extra batteries may be should the batteries be part of the problem. The system driver down below is a portable battery source, as well as information provided to the patient and the VAD coordinator. The far right, you have the power base unit for the HeartMate 2. This is exactly how it would look like in somebody's living room, probably on a coffee table in the corner. It's charging their portable batteries, as you see in the back of the picture, for the next day's activities. And it also provides power to them to be at home that particular night for the evening or during the night when they're sleeping. And then down below is just a heightened picture of what information you would see coming across that module system that's sitting on top of the power base unit. And it just talks about liter flows and how fast the device is working from an RPM standpoint. All that information is very beneficial, again, to the VAD coordinator and to the patient to clue in that there may be a problem of some kind and how that problem needs to be addressed. So we go to the next slide. And just to give you some perspective of where we've come with VAD technology, this is just an example of the total artificial heart system driver up until 2 years ago, a little more than 2 years ago, when the first patient was released in the United States on the Freedom Driver system, which is on the left. That weighs 13.5 pounds. That's doing the same job as what the patients had to stay in the hospital and tethered to on the right, which is the big blue driver. That big blue driver weighs over 400 pounds. So up until a little more than 2 years ago, 2.5 years ago, before the Freedom Driver was actually supported by the FDA, the big blue driver is what these patients had to push around throughout the hospitals until they were transplanted. And this is the total artificial heart. So these are the patients who had their entire native heart removed and artificial valves and chambers placed in. And then they had to push around this big blue driver every day until they got that transplant surgery. Well, now here we are 2.5 years later. The patients are walking around, they're at home, they're going back to work, they're going back to school, because now they're only tethered to a 13.5-pound Freedom Driver system. So remarkable changes are made in this industry that's making the population bigger and bigger and bigger for us to tackle as pre-hospital providers. Technology is getting smaller, more efficient, not only in the device itself, but also with what's providing its power and information. So technology is really, really taking a big leap here. If we can go to the next slide. Remember I talked about the BiVAD, where the patients can have left-sided and right-sided ventricular support? We may not be seeing a ton of those people into the community as much as we see the LVADs, but they do exist. And this is actually a frontal view of the Thoratec system driver for a BiVAD. If I were to take a frontal picture, it would actually look like a little carry-on bag on a set of wheels. But this is the panel in which you would look at if you had to troubleshoot a BiVAD. And if you look where it says LVAD in the red and RVAD in the blue, there actually are hoses that connect to the LVAD into the RVAD. And next to those would be two little blue bulbs sitting on top of this system driver. Those blue bulbs would become the backup plan should this system driver completely fail. And those batteries that you see on the left and the far right were to completely die. And for some reason, this system driver completely shut off. You would disconnect the hoses that went into the LVAD, into the RVAD, and you would connect these blue bulbs that would be laying next to them, and you would actually take over the left ventricle and the right ventricle by squeezing these blue bulbs and pushing air in and out of the drive line that would keep that BiVAD working and keeping the chambers moving so blood clots don't form. So that's kind of an important thing. It's a bit overwhelming when you first look at it, but the key elements is to know where those attachments points are, the LVAD and the RVAD, and that this is something, if it's pneumatically driven, find out if there's a hand pump of some kind that goes with it. This particular one, it's two little blue bulbs. and those blue bulbs actually become essentially your chest compressions. So it's a very important take-home point. But this is just another view of basically another form of a system controller. So they can be a little complex and a little bit overwhelming, but that's what we're facing in today's times within the EMS industry. If we can go to the next slide. So how does this mean anything to us? How do we modify our patient assessments now that we know that there's pneumatically driven cardiac assist devices, there's continuous flow cardiac assist devices, we know pneumatic, they will have a pulse, it's pulsatile flow. We know continuous flow, it's not pulsatile. So they may or may not have a pulse. The reason why they may or may not have a pulse is depending upon their own native heart function and the strength of that native heart. If you feel a pulse in a continuous flow device patient, they still have strong enough of their own heart muscle working, and that's what you're feeling. But it's not significant enough to provide good cardiac output. So the device is providing the remainder of that. So you may have a patient that has a pulse or a patient with no pulse. So it's an important question to ask. So you know, if they say, I do have a pulse, I do have some heart function working adequately, then you will know the difference if this device stops. You won't be surprised if they still have a pulse that's working. It may not be very adequate. They may only be alert and conscious to talk with you, and that's about it. But it's important to know one versus the other. If the patients have no pulse that's palpable and the device takes over all of their cardiac output and it's a continuous flow device, which does not stop, then you need to be able to remodify your assessment of this patient. So then you're going to lean more towards how well is the patient perfusing, their level of mentation, their overall color, their perfusion, are they dry, are they diaphoretic? All those things will put more weight on than versus whether you have a pulse or a no pulse. Now that can get tricky for us because we put a lot of weight on those values and how we take care of a patient. So that gets a little bit tricky, along with MAPs versus systolics and diastolics. Mean arterial pressures is usually not something we do pre-hospitally, which can complicate things a little bit. An ideal MAP for an LVAD patient is around 65 to 70, but we work more towards your systolics and your diastolics. So if it's a continuous flow device patient, you may get a systolic diastolic that's like 90 over 80. It's not going to make any sense to you. So that can complicate how we carry out our protocols. So if we can do MAPs or calculate MAPs in the field, that's ideal. But unfortunately, a lot of pre-hospital protocols are not geared around MAPs. They're geared around systolics and diastolics. So we have to be able to modify that part of our patient assessment. Same thing with SpO2 monitoring. If I don't have a pulse, I'm not going to get an accurate SpO2. So I may have to rely heavily on my CO2 monitoring as far as how well the patient is doing. And that's becoming a commonplace thing in the EMS industry. And again, rely heavily on your physical exam. This is a very hands-on approach to patient care. Are they moist? Are they dry? Are they pale? Are they diaphoretic? Are they making sense? Are they alert and talking? And for people that are ALS, EKG monitoring, again, we have a disconnect now between your electrical activity of that heart that may still be working from the mechanical aspects of what the heart is actually providing. We have a device providing mechanical, but we still have electrical activity in the heart muscle. So think about PEA with perfusion, a pulseless electrical activity in the heart muscle, because you don't have a pulse with this patient because they're a continuous flow device, and the heart muscle wasn't really that strong, but they have adequate perfusion because of the device is providing it for them. So you may see a rhythm on the monitor that you just can't even identify or isn't conducive with a patient sitting there talking to you. So be thinking about how this device alters every component that we've come accustomed to up to this point, our traditional vitals and what our cardiac monitor is telling us. So we can only put so much stock in those normal values with this type of patient profile. So we have to rely heavily on that physical exam. Next slide. Questions that we want to ask, we get our typical history, allergy, medications, but we specifically want to ask, in addition, do you have a pulse with this device? The patient will understand exactly what you're asking them. Do you have a hand pump of any kind? They will be able to tell you yes or no immediately. Where is your emergency backup bag located? If you're in the home, find out where that bag is located. If they're in their car from an auto accident or you're picking them up at a shopping center, find out where in the car that bag may be located. Some of these patients may not take that emergency bag with them because they think they're just going to be gone for 10 minutes. But it's an important question to ask. And this backup bag should have extra batteries, an extra controller. Any emergency intervention tools that they need for the device should be in that backup bag. If they're not able to answer you for some specific reason, look for anything and everything that can carry 4 pieces of equipment, whether it be a camera bag, a cooler, a backpack. Some of these patients don't want to stand out, so they want to put something like equipment such as that in something a little less obvious. So look for anything that may be able to carry 4 or 5 pieces of equipment and check inside to see if, in fact, that's their backup emergency bag. Where's your home power source located? Or do you have a portable power cord? A lot of these devices are now coming out where they can plug into a cigarette lighter or a regular outlet and charge the batteries or keep the device running so they can be plugged in almost anywhere. If they have a home power source, take it with you to the hospital or wherever it is that you go so that patient can stay for lengthy amounts of time and know that there's a power source that they can plug into. How do I reach the VAD coordinator? In today's times, almost all these devices have phone numbers either on the controller or on the tag associated with an emergency bag or any kind of power source. That tells you exactly how to contact their VAD coordinator who manages these patients, if these patients don't already have them on the phone when you arrive. That VAD coordinator is going to help you through this emergency. And any deviation from your protocols that they may ask you to do, make sure you pull your med control into the mix to make sure you get med control clearance. But that VAD coordinator is going to play a paramount role in helping you manage these patients because they know them very, very well. Do you have a binder of information about your device? Many of these patients do. They can tell you exactly what their leader flows have been doing. They can tell you exactly how many RPMs that their device has been running at and any complications they may have had over the course of a week or a month or any set amount of time. That information is very important to bring with you. So anybody who looks at it after the fact can see a history profile developing. Next slide. Medical assessment. Obviously, airway breathing has not been changed. Check the LVAD. Listen to the LVAD. Go a little bit below the left apex of the heart and listen to see if this device is pumping. If it's a pneumatic-driven system, you may be able to hear that thump, thump, thump as you're approaching the patient, which confirms the device is working. If it's a continuous flow device and it's a very small turbine hum, you may actually have to listen with a stethoscope and actually listen below the left apex of the heart muscle to determine whether this device is running or not, or if there's any alarms that are actually alarming when you approach the patient, telling you the device is not running. Then assess your circulation. And if they don't have pulsatile flow, pulses with that pulsatile flow, then obviously use your other assessment skills in telling you whether the person's perfusing adequately or not. Again, LVAD version of vitals. We've lost our systolic and diastolics as we know them, and we may have lost, the heart rate and pulse check as we know it. Check the device assessment for disconnections. So start from the patient, work your way back to the device, check every point of connection, make sure something didn't become disconnected, which would be a very easy fix. Or start from the device and work your way towards the patient, checking every single thing that could possibly connect or disconnect. Check for battery power. Every one of these devices will have some kind of gauge to tell you where they are with their battery power levels. System module, if you're at home, the patient's at home, and they have a system module and they're attached to it, look at the information on the screen and convey that to the VAD coordinator. They'll be able to tell you what needs to be done next should the patient need IV fluids or whatever have you. And then think about other causes for the emergency. The LVAD can play the elephant in the room concept. Everybody wants to go to the elephant in the room when that may not be the cause of the emergency, especially if the patient is known to be with no pulse because of the device that they have. The patient could have a sugar level of 20, be unconscious, diaphoretic, breathing at 6 times a minute. It would be easy to hone in on the device and having that be the cause of the problem, but the device is perfectly fine. The problem is your sugar is 20. So think about other causes once you've ruled out this device is working properly, making sure it's not an overdose and there's not indications on the scene of a potential overdose. Get past medical history, allergies, medications. These patients will have those histories. And utilize patient and family for LVAD troubleshooting. They live with the device 24/7, so they are the experts on how the device works and what complications that they may encounter. The patient's conscious and talking, interact with them. They know exactly what they're talking about and follow their lead. They just may need an extra set of hands. Next question. Next slide, I'm sorry. Again, AB, airway breathing, check the VAD and circulation. There are no C-spine immobilization modifications. Just be cognizant, though, you don't want to put anything tight across the chest. You do want to do a trauma assessment of the patient and the LVAD. If the patient hit a tree at 80 miles an hour, so did the LVAD. So you want to make sure that nothing became disconnected or dislodged. Can I use a KED, the Kendrick's extrication device? If you think about how we use it, and we cinch down across the chest as the last step before we take them out of a car, that probably would not be a useful tool with a patient with an LVAD. Was there an airbag deployed in the vehicle they may have been in? Ideally, they shouldn't be in a car with an airbag that's still active, but if they are, think about the amount of pressure that went to their chest that may have disrupted something with that device. And getting them to a trauma center that can take care of that VAD emergency as well, should it surface, is ideal. Is the trauma isolated and the local ER can meet the patient's needs? If it's somebody who's stepping off a curb and they just didn't see the curb and they twisted their ankle, that's a completely appropriate transport to the local emergency room if that's all they need, is an x-ray and a splint. But certainly field that with the local ER physician. He or she may not want the patient in the emergency room because if something goes wrong with the device, they can't manage that issue. Or the VAD coordinator may want that patient brought up to their VAD center regardless of the basics of their medical needs. But it is a possibility, so that's really something to kind of work through logistically. Next question. Next slide. Patient packaging on the stretcher. This picture depicts basically the wrong way to treat the system controller. As you can see, it's attached to the drive line that's coming out of the patient's abdominal wall, in this case the patient's shirt, creating a great deal of torque and pressure. So you really want that controller sitting more centralized in the middle of the patient's body and nothing pulling on these cables. We can go to the next slide. This would be the correct way to package this patient. And try to put the straps, the stretcher straps, or the spider straps, if you were to spinally immobilize, underneath the controller and their cables, so there is no torque or pulling on these cables in transport. And just make sure that they stay centrally located to where there's nothing pulling on any of these cables at all. Next slide. Okay, we talked about keeping spider straps loose across the chest, not over the controller or the cables. If possible, consider transporting to a hospital capable of managing trauma and VADs. That's a very important take-home point because they may have complications on both avenues. And be careful with the scissors. I know we've had cases here in the Mid-Atlantic region where cables were cut accidentally, and if patients are critical, some people do tend to get a little kind of loosey-goosey with the scissors. We don't want to cut something that's basically going to seal the fate of the patient. So if you do palpate something underneath the clothing and it's something that shouldn't normally be there, like a controller or batteries, make sure you expose the patient first before you start cutting around these key elements, because once we cut any cable that may be that drive line, we kind of seal their fate. Next question. Next slide. CPR, this is one of the big controversial topics. Obviously, airway breathing is still the same. Evaluate, has the pump stopped pumping? This is paramount to listening to under the heart to determine if the device is still running, whatever the device may be. and then assess for pulse just because they may have that native heart function still working for them. If you have a patient that you deem is in cardiac arrest, the pump is not pumping, or the pump is pumping and the patient has no signs of life whatsoever, it's still a controversial topic whether or not you start chest compressions. So it's really paramount to get protocols written and put in place to help you decide whether that decision is to do CPR or not, and get the VAD coordinators on the phone as soon as possible. They will help steer you in the direction of what that facility supports, whether chest compressions are done or not. Obviously, with the points of attachment, you can cause exsanguination very, very quickly if you dislodge one of those cannulas. Next slide. Special considerations, non-VAD emergencies, again, susceptible to trauma and other medical emergencies. Just be cognizant of that. Don't let the device overtake your assessment. And consulting with med control, you may find that your local emergency room physician may not be too familiar with an LVAD. So the conversation may have to get quite detailed in exactly what it is you're dealing with and whether that patient should go to a different facility other than your local community emergency room. Same thing with whether you transport ALS versus BLS. It may be a BLS injury, but that BLS provider may not have the proper education and training to feel comfortable enough to transport that patient to where they're going to defer to an ALS transport team. Next slide. Transport destination and options. Again, it's emergency driven. If it's an LVAD emergency, they need to go to an LVAD center, ideally the one that treats them and manages them. Resource and protocol driven. You may not have the resources to take an ambulance out of your area for 2 or 3 hours to drive the person to that VAD center. You may need air medevac resources pulled into the mix. Obviously, that's going to be resource-driven and protocol-driven. But one of the take-home points is start working in the direction of creating a protocol and a directive in how you're going to manage these patients so these emergency questions can be answered before the emergency actually occurs. If it's VAD-related, again, a VAD center is optimal. They're the ones that are going to be able to manage these patients the best. Then again, obviously, non-VAD centers, local emergency room may be adequate. Today's HeartMate 2 GoGear patient, this is some of the equipment that you may see around the patient's waist. This is today's GoGear. It basically sits around the waist and protects the batteries and the controller quite nicely instead of them being out and exposed. Next slide. Are there any altitude concerns? No. These patients can pretty much go by helicopter. We don't climb high enough for there to be a concern, and they can honestly do commercial flying as well. So these patients aren't limited in that capacity. Next slide. Pre-planning for the VAD emergency. Med control, again, we talked about the VAD knowledge. They may or may not have a lot of knowledge on these devices. So pre-planning and pre-discussion is paramount. Know your transport options. By air versus ground. Who can do what, who can provide what, and what resources do you have available to you. Know where your nearest VAD facilities are, so you know what hospital to send these patients to, and see if you can pull them into the mix in helping with your future education and training. And again, protocol and directives, development is paramount. You want to have this pre-planning done before the emergency surfaces. Next slide. Things that should be in this protocol content, brief explanation of the generic management of any VAD patient, regardless of the device, that they're volume dependent. It doesn't change anything in your ACLS protocols. Incorporate the 2012 EMS VAD field guide as part of your protocol. This 2012 EMS field guide is used across the country now, and it's actually straight from the manufacturer's mouth, and it's 10 key questions that we need to know in an emergency situation. And each manufacturer answered one of those 10, all those 10 questions exactly to what it is we need to know at 2 o'clock in the morning in a true emergency. That should be part of your protocol. Get your OMD involved and get their support. They are our med control, and they're the ones that we practice under. And then provide guidelines on VAD and non-VAD emergencies and transport options before the emergency occurs. So know all of this information before you actually encounter one of these patients. And then the big question, direction as to if and when to initiate CPR. Somebody in your individual system needs to take the lead on whether we do or do not chest compressions on these patients. Next slide. And what does it all come down to? Getting back to a quality of life. This is what this is all about. These patients before probably couldn't even walk across the room. Here they are playing golf, traveling, and helping in the kitchen cooking. This is what these devices are all about, and this is where they're proving their weight. Getting these people back to a quality of life, getting them out of the hospitals, and back to work, and back to travel, and back to what it is that they want to do. So these patients are lasting longer with these devices, and it's creating to be, a fruitful life for them, which they probably didn't know for quite some time. Next slide. This is a growing demand for us, for EMS. Less organ donors creates longer transplant lists. So we're seeing these patients 2-3 years with these devices. Technology is getting better and better. They're creating smaller and more enhanced, less complicated devices. And the patient population is booming. We're going to see this just grow. We're not going to see a patient population decrease. We're going to see it increase. So we have a lot of groundwork to get done on creating our industry capable to manage these patients. Next slide. Again, here's some websites for you to go to, www.mylvad.com. You can download a color copy of the 2012 EMS Field Guide. Again, it's designed around 10 key resuscitation questions pertinent to EMS in the field. So it's designed for our industry and what our needs are. Next slide. There is a Thortec EMS training video that we did back in 2009 that's available at www.thortec.com, and it goes from the initial patient assessment of an LVAD patient all the way to medevacing the patient from the local emergency room. Discusses transport, packaging, assessment, every aspect, and it's about a 15-20-minute video that will also aid you in your EMS training initiatives. Next slide. And here's some more websites for you to go to. Again, mylvad.com, thortec.com, heartware.com, jarvikheart.com, and sicardia.com. That will help aid you in all of your training initiatives, presenting any kind of training goals and objectives for your personnel at your firehouse. And I think I'm 5 minutes under the wire for any questions.
If you are okay, I will unmute the phones now. Give me 2 seconds. Let's try this again. There you go. Does anybody have any questions for Barb?